My name is Alan Higgins. I'm the Health Equity Network lead, and I'm looking for Alison on the screen. There you are, Alison. Would you want to introduce yourself?
Hi, everyone. I'm Alison. I'm the Health Equity Network coordinator.
And thank you very much for joining us today. This is one of our regular monthly webinars, which we're actually delighted that we've been able to run one every month, more or less since the beginning of the network in January 2023. And if you have been on before, you'll be familiar that we try to keep this discussion fairly informal. We will have two speakers who I'll introduce in a moment. And then after speakers, it's over to people on the call to ask questions, make points, to have as much opportunity for speaking up about your thoughts on the subject as well. And you can do that by using the hand facility, and if that's not working for you, then just wave at us and we'll make sure that we pick up the conversation. We will finish by 1:30. We'll make sure we stick to time. And just a hello to a few more regulars here. Hi, Melanie. Hi, Lisa, as well. And good to see you. And the theme for today is health and productivity, but particularly looking at implementation science as it relates to the theme of health and productivity, which is something that I'm particularly interested in because we can work on strategies, we can work on plans, but actually putting it into practice is another subject in itself, and learning from others about what to do that will help us succeed is also very important. So I'm delighted that today we've got Elizabeth Bachrad from Business for Health. Elizabeth is Population Health Strategist and Head of Programme Strategy at Business for Health. And we also have Chris Edmond, who was a very early supporter of the Health Equity Network. Chris is Medical Director of Work Health in the Channel Islands, the only occupational health provider for the Channel Islands. And I'm going to hand over to Elizabeth to run the input, which will go for about 20 odd minutes, and then we'll come back for questions after that. You okay to go now, Elizabeth?
Yeah, I'm ready to go.
Take it away.
Fabulous. Welcome, everyone. We're very excited to have you all here, and it looks like a lot of work and health connects across the chat, so that's really helpful. And I asked Chris to do this with me because we've been working in this space for a little while now, and we'll talk about our research in a moment. But today is a little different. We're not going to do a PowerPoint. We are going to have a chat and discuss our respective research streams, our work streams, and what we're seeing across the space and implementation science, how that connects to work and health, work and productivity. And a special twist on that is to add in systems thinking perspectives and the views of how that integrates and accelerates our adoption of interventions. So this is going to be a conversation. We welcome comments and questions in the chat, and we'll do our best to answer along the way. But of course, afterwards, we can engage and connect with everyone. So Chris, welcome. I'm so excited to be chatting with you today, this afternoon.
Me too. Thank you, Elizabeth.
Yeah, absolutely. So I'm going to start with one question that I'm wondering if everybody is thinking, and that is the weather in Jersey as rubbish as it is here in the UK right now?
It's a bit cloudy and a bit rubbish. We are the sunniest place in the British Isles. It doesn't feel it today.
Okay. Well, yeah, it's been one of those weeks, if not months. So,
yes.
Anyways, so Chris, you're in Jersey, which is very unique in all of its respectful ways. Can you tell us a little bit more about your role and what stands out in Jersey compared to what is happening in the UK around work and health?
Absolutely. So I'll give a bit of background. So I'm an occupational physician. So my job is looking after people's health in the context of their work. So I see individual employees when they've got health problems. I see people in safety critical industries, making sure that they're safe for their work. We try and protect people from work-related risks. But I don't know if it's certainly not a unique perspective, but I very much see occupational health and occupational medicine as an applied form of public health, We do everything that a public health practitioner would do in terms of looking at health across a population and looking at the factors, the sort of determinants of health that affect that population. It just happens to be our population of interest is the working health population. So we look at how do we protect them from risks, how do we do health improvement initiatives that are work focused, and how do we work with employers to sort of put health up the agenda. I mean, we were talking earlier and touched slightly on well-being and the overlap with well-being and health, but I think health specifically has been left out of that conversation a bit too much. So I take a very wide focus of my work, as well as being an occupational physician. I'm a director at Jersey Sports, which is our sort of equivalent of Sport England. I'm on the board of a mental health charity. I've recently set up a lifestyle medicine charity to look at other ways that we can improve health in the wider community and not just at work. I do quite a lot of sort of political, so certainly touching on political activities, and I write a column in the local paper as well, all about trying to link those things together, because as we've spoken about before, we spend a huge amount of our time at work. If we don't address through our workplaces the factors that are contributing to ill health, then we're missing out on a huge opportunity in terms of health improvement population wise. And I guess the question on Jersey and why Jersey's different is that Jersey's a really interesting, so we're an island of 103,000 people, well known for our finance industry, but actually we've got industries across utilities, retail, tiny bit of manufacturing, a lot of digital industry, quite a lot of health related employment, and the government also being the largest employer on the island. And Jersey's a really interesting place in which to look to experiment in terms of how do you implement change. We're an enclosed population, we're an ideal research sized population of around 100,000. And I think what struck me over the last few years in trying to do systems wide change is, even though you've got a small captured population where you have access to all of the levers that we look at in terms of systems change, it's still really difficult. And it's still really hard to engage all the necessary levels at the same time. So I think we're a unique and interesting population where a lot of the work that we're all talking about in terms of the health equity network should be easier to deliver here, but isn't necessarily. We kind of, if you look at the integrated care board structure that's now been set up in the UK, we have that already. We have a unitary authority with one health system. So we've been trying for years to achieve what the UK is trying to achieve in NHS terms, and it's still not easy.
Not easy indeed. I mean, I think that's part of why we've had so many discussions about how we can accelerate this aspect of it. And we'll dig into a little bit of what you mentioned, because you talked about a lot there. So from our perspective, so I'm head of program strategy with Business for Health, which is a social venture, a community interest company that is focusing on catalyzing and facilitating business contribution to health outcomes while reducing inequalities. And that hard part of it is really around breaking down this false dichotomy of economic growth versus public health, right? We have to think really differently about advancing policies that move both forward together. So part of why I wanted to talk to you today is really to get your thoughts, and we'll go back and forth on this a little bit about why it's so hard to implement research into practice. And so just for the audience sake, and I'll help supplement this, what is your view of implementation science, and what does that mean in a business and work setting?
Very good question. So I think implementation science has kind of grown in the health setting. So I'm not an academic, I'm a sort of coal-faced practitioner, as it were, trying to do the implementation. But over the last sort of 10 or 15 years, the concept of implementation science has grown up in the health sector, particularly looking at why do we have a gap between research and practice. And in medicine, that gap is typically said to be somewhere between 10 and 20 years in terms of research studies getting into coalface practice. So the sort of academic subject of implementation science has arisen, to look at that gap and to look at, first of all, what's causing the gap, what are the factors that lead to that delay in implementation, but also what models can we implement to improve that and to shrink that gap. I think in a health setting, we're starting to understand more about how you apply actually quite a whole systems approach to implementing change within a healthcare setting. We're understanding the barriers to change, we're understanding the drivers to change. We're getting better at doing studies that look at various models of implementing new clinical practices, new ways of working, new medical treatments. So I think at the level of the healthcare system, we've moved quite a long way forward. And if you read the journal Implementation Science, which focuses solely on this practice, there's a lot of studies that are showing what works in that setting. I think the difficulty and the complexity in the work setting and why Business for Health's work is so important is that we're looking at a far more complex system with far more actors involved, with far more drivers of business that are different to the drivers within the health system. And then you're adding on the political dynamics of it. And I think everyone will have seen in the last week the announcements from the UK government in terms of how do we look to change the fit note, how do we look to change work and health support systems. So we're working in a very complex political space with lots of actors, and nobody as of yet has managed to successfully study in its entirety, because of that degree of complexity, how do you do implementation science in a business and health setting using a whole systems approach. And that's why I take my hat off to you and Business for Health for attempting to do that, essentially, because there's a huge degree of complexity in there.
Yeah, absolutely. So this is perhaps a great time to introduce some of that research, and some of my colleagues on the chat here have been heavily involved. With implementation science is really aiming to accelerate this adoption of evidence-based interventions. I think one of the challenges that we see is that there's a lot of practice examples that aren't evidence-based yet, but that really are working. And so part of what implementation science, the essence of it is, well, what is making it work? And this is where some of that context comes in, as you mentioned, the wide stakeholder mapping that needs to be done to understand, and why I love the work that we do around leveraging systems thinking to do this is that it's really about understanding why we've been unsuccessful in solving some of these chronic problems, despite our best efforts, but despite employers being having good working conditions, for example. We know there's a lot of room to grow in that area, but the systems view, it can't necessarily fully answer those questions, but it can illuminate how people think, the consequences of the thoughts and actions, and then really help people see new sustainable solutions. And so Business for Health has attempted to tackle this through researching and funded by the National Institute for Health Research on the work and health track, is looking at that systems view to define metrics and indicators that are health relevant, that can be shared and linked across these integrated care systems, and in Jersey, what you have in your integrated setting, and work towards the same outcome. So we're looking to work with joint strategic needs assessment from ICSs, share that to the business community, invite chambers of commerce in, start to work on some of these strategies together, and distill a set of metrics that would eventually be able to help support the ONS, for example, Office for National Statistics, in widening their remit around how they look at health, and hopefully bring back the health index with some more granular data around business. And part of that too, I think, is understanding these vicious circles that we've been trapped in and that we can't seem to get out of. But we really want to create these new patterns of relationships that serve us better. So if we're going to take this implementation science approach, which is about getting the adoption and integration of these evidence-based policies, practices, including some of the practice examples that need the evidence base. How do you see us engaging stakeholders in a new way? And Business for Health is working on this, as I mentioned, but what is the essence of our people and how people's assets can help us close some of these gaps?
That's a very good question. I mean, I got involved with sort of the Health Equity Network early on, after the Marmot report on the business of health equity that looked at business health in a far wider context. So it looked at health in terms of employee health and community health and customer health, and the effects that business has had on the wider range of stakeholders. And that's what really caught my attention initially, because that's naturally the way I think about business practice anyway. But I think that conversation hasn't yet been embedded in a high enough position, particularly politically. It's starting to, but I think engaging that wider group of stakeholders is necessary, but it's looking at the individual drivers for any individual stakeholder getting involved. So the ongoing conversation that's happening, particularly nationally in the UK, about productivity, about long-term ill health causing problems with work, about the workforce shortage that is going on, and we have exactly the same issues here in Jersey, starts to then put some political pressure on making that change, and hopefully starts to get governments to engage with things like the Health Equity Network. Interestingly, we've had a change of government here locally recently, and that clearly is likely to happen in the UK at some point. You are having those conversations now with the right stakeholders in the preparation for a likely change of government. But then it's looking at businesses, and what I find certainly in my professional practice is that there's plenty of appetite within businesses for getting engaged with the health of their employees. There's a conference on this week in London looking at health and well-being at work, and it's a regular topic of education within most corporates these days. But I don't think what's not been explained to them at this stage is the what works bit. Unfortunately, we're talking in the week where the What Works Centre for Wellbeing is closing down, but they've done some fantastic work on starting to prove what works in those settings. And I think that's why when I said earlier about working across the whole system, is that we need to drive the conversation forward in terms of the people who understand the evidence base, the people that can explain the evidence base, the people who can explain it at a political level, and that can then start to contribute to those conversations nationally. And I think from my own profession, the Society of Occupational Medicine have done an absolutely incredible job in the last few years getting involved in those political conversations, getting comments out in the media, driving the academic research agenda forward so that we can prove what works. The NIHR program that is funding your project is a huge step forward in itself, that we now have a work and health research program. And hopefully that will then start to give us the evidence base to then take to the organizations and prove to them what works. And then if we can start to get the data collection right, we can then feed that back in the other end, and continue that cycle of improvement.
Absolutely. So when I was posting about this webinar, I had a reply from a colleague that I met at the World Happiness Summit. And he wrote, leaders not only need the willpower, which is the desire, obviously, but the way power. So the means to do what we want. How do we do this? And so I think that's what's drawn me to implementation science, is it really picks up that context of what works. And for academics, a realist perspective around what works for whom, under what circumstances. And I think this is the nut we have to crack is, okay, we know a lot of things work actually, but what makes it work? Who makes it work? How do we make it work together? So my next question is around the strategy, because you have the science and you have the theory, but you need strategies. It's not going to be one, right? You're going to have multiple at different times during the implementation phases. What do you think around what are the best strategies to best integrate these evidence-based interventions into community setting and as well as a work setting?
I think the question you asked there in terms of who makes it work is vitally important, and unfortunately that makes it very difficult to give a straightforward answer, because it depends entirely on the setting, the people involved, the history of that setting, the culture of that setting, and so often the people within that setting. I mean, we've connected over a shared passion for the topic, but there are plenty of other people out there with the shared passion of the topic, and it's about finding those individuals at every level within the system. So thinking politically, thinking academically, thinking the heads of organizations, thinking of the chambers of commerce and the Institute of Directors and the CBI and all those other large business representing organizations. But then what we're actually finding is that businesses are getting better in terms of strategic implementation of traditional well-being initiatives and well-being strategies, and they're getting better in terms of sort of their development and delivery of engagement strategies and the measurement of those. And so I think the practices in terms of how do you develop a strategy, how do you analyze the data that you've already got, is getting better within businesses. And if you can apply those tools that have been used in those local settings that have developed their wellbeing strategy, that have developed their engagement strategy, and that we can then start to apply them in terms of how do we develop a broader health strategy. And we're seeing it a lot in terms of the wider ESG agendas with businesses about how they start to measure their environmental and social impact, and having those conversations about, well, how do we add health into that and into those national metrics, because that will be a natural driver for them to start measuring it. But I think when you mentioned the idea of sort of realist implementation science, I've thought for a number of years. I've got a computer science background, and if we got enough data to plug into the big machine learning models in a place like Jersey, where you've got 100,000 people, it's a relatively stable population, or any similar population within the UK, can you start to do a very large scale naturalistic cohort study that then starts to pull out all of that health relevant data, pull out the business data, pull out the HR data, the productivity data, the sickness absence data, the health system data, and start to build that up in a far more naturalistic way, so that rather than having to run an individual expensive large scale randomized controlled trial, which in a realist setting is quite a challenge, can we start to just use the techniques that are coming along in terms of AI to do that analysis for us in a far more it's a more observational way, but a slightly more deliberate way, in the terms that you're putting in an intervention, you're then using the data that you're collecting already to measure the outcome, rather than having to put an entire research framework around it. That would be my utopia.
Yeah, I mean, that's really interesting because we want the robustness around the rigor, the academic rigor, right? But as you say, and as you said earlier, the lag time between what we understand about that research environment and how we put that into practice might take too long. So we have tools like AI now. We have automation of data capture. We want to integrate those too into how we effectively synthesize that data in order to make decisions around it. So to me, that is actually part of intervention success, right? Is having some of that groundwork and that foundation built and that infrastructure enabled, so that the stakeholders can engage at different levels. But that's also hard. that's really hard, and we know that it is a longitudinal approach. What other factors would you find that influence intervention success?
Well, I think having those basics in place, having the infrastructure, having the data sets, having the relationships, I think is hugely important, and building those relationships, not necessarily knowing where they're going to go in that sort of emergence phenomenon systems thinking way. um, having businesses talk. What I sit between businesses and the health system, so I see both sides regularly, and what I spend a lot of time doing is trying to link the two together, and getting person A over there to talk to person B over there. And you don't really know where that link's going to end up, but starting that, building that network of relationships out, so that our business people are talking to our health people, are talking to our government people, are talking to our academics. I think having those foundational relationships in place is probably number one. And I think the integrated care structure in the UK is hopefully going to drive some of that forward. Having the fundamental data processes within that, having standardization of data collection across businesses, and that involves getting the national authorities involved in how that's likely to work. They're probably the main foundational elements, and then again it comes back to having the right people with the passion and the drive, and the energy to get these things delivered. I think it's really important to recognize that this is hard work, but it's hard work with a huge amount of value, and the funders within the system, be they academic funders, philanthropic funders, commercial funders, have to recognize that sort of large scale system change takes a long time, and it's going to take a lot of funding, and it's going to take bravery in the way that things are funded, because when we start these processes, we don't know what the outcome is going to be. So I think having discussions with the funders of all types is really important now, so that we can get their commitment to that long-term funding, so we can address the major challenges that we need to address.
Yeah. So overcoming those challenges, particularly around funding, is crucial. And I think this is where the business buy-in and what we're looking for, especially around business for health, is integrating those stakeholders and the buy-in that there is utility for this, that it will lead to productivity gains, that economic growth is not at all costs, that we have to look at this as a way of building community wealth. And that's something that I know resonates quite strongly with OHID. So I'm very connected to this mission. I think the art of possibility is massive. And I guess my last question before we open it up to questions and discussion is, how can we adapt these effective interventions in different settings, and why is it so urgent, especially as around 42% of the burden for health and early death is attributable to modifiable risk factors?
Well, I mean, I think you just answered the question in terms of why it's so important that we do it. We are economically relatively stagnating. We are seeing a huge increasing burden of non-communicable diseases. We are facing an aging working population. We are facing climate change challenges. We are facing different work-related risks going forward. And unless we start to address those challenges, we're not going to have a happy, productive, healthy society going forward. So I think and that's slightly the frustration of this sort of work, is that the business case is clear, the economic case is clear, the health case is clear. The challenge of reproducing specific programs in different areas is a huge one, and that's why it's about matching the initiative to the right level, and making sure that we're not trying to drag and drop an initiative that worked in one place and dropping it in another place, because you've got to recognize the business community is different there, the history is different there, the health community is different, often the health challenges are different. So it's about making sure that the data that we're collecting is granular enough that it's useful at a local level, that we can then prove the business case as far as we need to, in any local level. I think the fact that the national conversation is happening at this stage is helping us drive those conversations at a local level. It's helping us engage with businesses. It's helping both the business community and the health community recognize the importance of long-term prevention and changing our models of care to being far more preventative. And the conversations that I have with businesses on a regular basis are very positive and encouraging. They want to get involved in this work. They just don't know how to get involved in this work. So it's taking, as we said before, it's taking at the larger system level some evidence and proving what works, testing it at a local level, and making sure that we are doing the evaluation that can then feed back into the implementation science piece, and then we can start to build the research base in what works in terms of implementation.
Yeah, I think that's a really strong point to finish on. As we understand implementation science and interventions, if it doesn't achieve these community and individual outcomes as we expected, it's important for us to be able to coach, guide, train, mentor, capacity build around knowing whether the failure is due to ineffectiveness of the intervention in the setting or ineffective implementation. And that's where I think an evaluation is crucial and doesn't often get done in a work setting. So that's part of our approach too, is to recognize that the leadership needed around systems and implementation is so crucial to understanding how the intervention works and why and what's needed. So
and making sure that that's built into the funding at the start of any intervention, and built into the business case, and built into the understanding of the business that's delivering the intervention, how important that is to feed it back in.
Excellent. So I see a question right away, which is the last one from Lisa. And thinking about intervention success, do we have thoughts on how we engage professionals who influence health but may not see themselves as part of public health? We get this question all the time. Business leaders do not see their role or understand their role in public health. Why is that important? And so I think you mentioned it earlier, Chris, around environmental social governance, which tends to float around this corporate social responsibility. And that's a really interesting way to engage. And we've been successful in that in the past, is to say that the climate space has been growing for years. And a lot of businesses understand, and employers understand their role in combating climate change, putting forward net zero targets, all of these things. So how do we build that robust health measures into the social aspect of that and create the opportunities to engage that way? And so Lisa gives an example of allied health professionals, such as occupational therapists, who support people across the lifespan to engage in activities that are meaningful to them. And yeah, that's a really interesting way forward, because our approach too is health relevant data. So it's not necessarily, we're not asking for necessarily mental health outcomes, which is already being collected on a national scale. We're asking for the working conditions that exacerbate or protect those conditions from existing. So that's another way to look at it.
I think there's also something about linking in, making sure that the workplace isn't forgotten in terms of other health initiatives. So, for example, I'm involved in a social prescribing program for the island about looking at how we embed social prescribing, and that should be as accessible in the workplace as it is in the GP practice. And I spend a lot of my time signposting people to non-medical interventions for the benefit of their work-related health, to manage their work-related stress, for example. And I think that the businesses are understanding the impact that they're having on the health and well-being of their people, but they're probably understanding it at the moment from quite a traditional well-being lens and mental health lens, but actually we're not looking at the wider impact that they're having on people's health and well-being, particularly in terms of their physical health. So if we can build on the understanding, because it's now commonly known or commonly said that your manager has far more importance for your health than your GP does. It's starting to build that into the business systems and making them recognize that. And that is kind of all of our responsibilities. This is not about occupational health taking over anything. It's not about management taking over anything. It's not about academia. It's about all of us working in partnership across the entire system.
Just before you go on, Elizabeth, I want to bring in Eunice, and just to say that I'm going to come to Fiona and Keris, just if you could come on and articulate your questions as well, because it's always good to get other voices on here too. Eunice, do you want to go ahead with the question?
Thank you, Alan, and thanks, Elizabeth and Chris. Excuse me. Just a couple of comments. So, I mean, I guess there is a role for business in being an anchor institution. I mean, this varies by the size of a business, whether it's big or small. But just as we talk about anchors as your local hospital, maybe your local university, places that aren't going to uproot and move to another part of the world next week, as the same applies for business. Some businesses are well established in local communities, and there's definitely scope there, I think, for business to connect with the health and social care agenda or well-being agenda in all its aspects. It's just one observation. It was interesting, actually. I just saw a post in the chat there, Bourneville, because I'm Birmingham born and bred, and so I know the sort of Cadbury story very well, and it's interesting to see their sort of Cadbury in housing. That was it, really. I've probably got other comments, but I'll stop there for now.
So a few weeks ago, I presented in OHID Southwest in Exeter on business and anchors, and exactly that, Eunice. It's as we talk about economic growth, what that does to businesses at scale is it uproots them from their community, or potential to, right? And so what we have to do is try to find why that shouldn't be at odds with each other, and what that means for the procurement and contributing to the fourth objective of social and economic value. When businesses grow, we can redirect those into the community, those resources into the community. So it really is a challenge, but that's also why going through the corporate social responsibility, enhancing those perspectives and making it meaningful and not just these one-off initiatives is actually about anchoring into the community.
And there's plenty of evidence out there that it leads to successful, more profitable businesses as well. I mean, I had the anchor conversation with our local government only a couple of weeks ago as the largest employer on the island. But also I have the similar conversations with our utility companies. I know there's issues with various utility companies in the UK currently, but they should be an anchor part of their communities in driving the health of the local area. So there are natural fits across a whole range of businesses, whether it's large factories or anywhere else. And I think Cadbury's is a great example. But you see it in Timpson's these days as being the anchor within most of the communities that they touch.
Excellent. Could I bring in Fiona? Would you like to pick up that question, Fiona, that you put in the chat?
Yeah, thank you so much for such an interesting conversation. You both referred to evidence and the need for evidence frequently during this presentation. And as a systematic reviewer, producing evidence that we hope is going to be useful, I just wondered, and we're trying to think very creatively around it, but I just wondered if you could speak from your experience and what advice would you have for those of us who are involved with evidence generation in terms of ways that we can make it really accessible and useful?
Well, I'd like to think the synthesis needs to be translated and communicated in a little bit more of a lay summary, if you will. And I mean that in a very respectful way. The idea of the dissemination around implementation science is probably one of the most important aspects of it, because it needs to be embedded, right? And so what we're looking for is interventions or practices, policies that are embedded in an operational environment. In order to do that, we need that bridge to bring that evidence, synthesis, translate it, communicate it, disseminate it. And so that chain is part of a strategy. And I think someone asked about models, and we can come back to that, because the models are what enable the communication strategies to effectively become embedded into an organization. And I think that's a really, really interesting question, and also one that we would crack this implementation science.
And I think, and part of what we're talking about is a PR exercise, and it's a lot of the initiatives that get delivered are unfortunately the ones with the better PR rather than the better evidence currently. And I think it's it's using, I think occupational health is a really has probably been missed out a little bit in past terms. We're very good at researching the effects of asbestos and what that does on the lungs, but we are very good at communicating risk to businesses, and we're very good at sort of communicating what might work in terms of interventions to businesses. But the link between pure academia and pure implementation has not necessarily been there in the past, and it's trying to use those bridges between the two in terms of how do you communicate, so that we start essentially to win that PR battle a little bit. So it's talking to those people that are talking to the people that you want to reach, and making sure that the language between the two is bridged across.
Excellent. Can I just bring in Keris? He's got a question about SMEs, which are the backbone of the economy in so many parts of the country. And there's also other points being made. Sophia made a point about Luton and micro businesses, which I think is in the same area. But Keris, would you like to go ahead?
Yeah, sure. And I think it links quite nicely to what you were just discussing. And in Wales, we've got a strong agenda with the Future Generations Act and trying to implement fair work, which obviously is aimed at the public sector, but very conscious that we've got a high proportion, it's 60-odd%, which are SMEs. So how do we ensure that the research and the data kind of is transferable, if you like, to those SME sectors?
So I'm going to tackle this first, and then Chris, please jump in. So Business for Health's target market is SMEs. And I know it may sound like this is large businesses that we're connecting with, but they've got the infrastructure more or less. Maybe not the outcomes, but they have the infrastructure. And so with our focus as SMEs, they're part of the co-production in this. So our full efforts in realizing our research around work health and work and productivity is SME engagement. What is it going to take? What is the motivation? What is the behavioral lens that we can approach SMEs? And oftentimes, as I mentioned earlier, public health is not on the agenda. So that's not the motivation. And that's okay, because we have systems leadership to do. We have capacity building to do. But I think with SMEs, our approach has been basically just asking, what do you want to see? What are you working on? Recruitment and retention. Reducing sickness absence. And then if you pull that back and say, okay, well, health as a lens can help drive recruitment. It can help retain your staff. They won't be off sick as much. They have supportive environments. They have social prescribing at work. So they have these interventions, but that takes a little while. So part of our approach to do with a toolkit that we've been partnering with Cambridge to use around improving improvement is to break down the personas. So you have your stakeholder mapping, and then you start to develop personas, and then we start to see the barriers, that the commutes are too long, that the starting hours, there's no flexible working, there's not mat leave, benefits. I mean, all these things come out that address the barriers, and then we can start to dive back in and say, well, what are some of the solutions? And you start to see that it's actually more about working conditions, policies and practices, leadership, and less about what type of health interventions they're offering. So that's the type of intervention effectiveness that we want to see, that is largely about these models and frameworks that provide guidance and provide permission to address these policies, or to address health outcomes through policies.
Yeah, I think there's also taking the opportunities where they are there. So, for example, all construction companies in the UK, all utility companies, will be sending their staff for regular health surveillance anyway, as part of the statutory requirements, making sure that they're safe for their work. And it's building on those opportunities, the potential for health improvement interventions. So a lot of the smaller businesses out there, I mean, Jersey is an economy dominated by SMEs, but a lot of them are interested in the health of their employees, and they're interested in seeing what interventions can they do to add on, because they already understand the productivity argument. They already see their sickness absence rates going up. And actually, a lot of them are already engaging with certain elements of it. You see things like mental health first aid becoming far more prevalent within small to medium businesses. But it's just building on that and having those conversations with them and seeing what is important to them as businesses. But they're often doing some things already. It's just how do we coordinate them, link them, and prove the impact of them and build on them going forward, and making it. And that's the good thing about the UK government starting to pilot access for occupational health for SMEs and trying to pilot subsidies for that, is that that's then looking at, well, how do we improve access directly for them?
Excellent. Can I bring in Anne Johnson? I don't know which borough you're working in, Anne, but you mentioned what looks like an interesting approach around a micro group of employers. Can you say a bit more about that?
Yes, thank you. Thank you for asking me. I work with Lloyds Bank Foundation, and they're working very closely in place-based work. And we are looking at and focusing on, because it's been seen as a key issue in the borough, about lack of aspiration, unlocking potential. We realised that that extended to the health and affecting the health of the people living in that borough. We found it was very easy to get the public sector into that space, and people who were impacted much harder to get the business sector in, because of a legacy of how we've worked with the business sector before, and we've always seen it about a transactional relationship. So what we started to do instead is stop and then work with bringing a group of employers together, cross-sector, cross-size, to actually put them in the driving seat, instead of us saying, come to our meetings, come to our events. So they've gone into the driving seat. It's very early days, but they're starting to look at what they want to see from it. What does good look like for them on a borough level? But I kind of still, there's always that friction, isn't there? Because then you go to the public sector to say, actually, this is what they're saying, and they're saying, but we're already doing that, and it's just that they don't understand. And there just kind of feels like this friction between the business sector and the employer sector and the public sector. So we're keeping them on separate tracks for a while, with the idea that you bring them together when plans are shaped, and therefore it's probably going to be received better from each side. But so that's the approach we're taking, and today it's kind of working. It feels like it's going to work, but it's very much on. It struck me to put it in, Chris, because you mentioned about things look different on a local level in different areas. This is kind of local up, if you see what I mean, as opposed to national down into local areas.
I think it's often the best way of doing things, isn't it? And I think again, it's that PR translation thing again, is that the businesses talk a different language to the public sector, and over time we're working on bringing them together so that they both understand what the other is doing. But that's a long-term project that's going to happen at different speeds in different areas, and you can only move at the speed of trust, as they say, and it's about getting each side to trust each other.
Excellent, thanks very much. I'm just looking at a question, Vincenta, that you asked about. Well, are you able to come on and talk that through? Sorry, I didn't give you any warning this time.
No, it's okay.
Go ahead.
So yeah, I would be interested in. So I'm a home worker. I work for a charity. The charity is based in England, but I'm based in Northern Ireland. And just taking what you've said, Chris, about things look different at a local level. So you could have many people, many employees with the particular charity or an organisation that is home based, whose office environments look very different and work environments look very, very different. And I think my own perspective on this is that an employer has a greater responsibility to those employees. However, my experience of home working is that a lot of that responsibility is placed on the employee. And so I feel as a person an individual responsibility in how I keep myself well. And I'm just wondering about your perspective then on the working landscape has changed, and we're more likely to be in a hybrid working environment rather than in a place-based, one particular singular place of employment. And about employers' responsibilities, I think that's not been bottomed out yet. Yeah, we've not had a discussion about it yet. But I'm, as an employee of a working from home, it's a conversation that I would like to lead within my organisation.
And the interesting legally is that that's your workplace, and your employer has exactly the same legal duties to manage your health and well-being and safety in that workplace as they would in any other workplace. Obviously, there's complexities to that because they don't have access to it. They can't come in and do what they want to it. They can't refurbish it, but they still have the same responsibilities for doing the same level of risk assessments and providing you with the same same sort of level of input as they would do with an office-based employer. And I think it challenges us from a data collection point of view. For example, some employers have got blood pressure kiosks in the office. Well, are we going to make that equitable and give people who are home working access to regular blood pressure monitors? Potentially. And that's probably the future in terms of wearables. The real challenge and the real sort of difficulty is then where's the employer overstepping in monitoring you at home, and things like activity monitors. I mean, I was reading recently about a sensor on people's chairs, and the employer could see when you're sat at your office desk. That is overstepping the mark, and that's not going to do anyone's health any good. But there probably are things that they can be doing in terms of helping home workers to both monitor and improve their health and well-being. But you're absolutely right. It's very much the early stages of that conversation. I think a lot of businesses have put it to the back of their mind and gone, it's fine, we're all going to go back to how we were eventually, so let's not worry about it. The reality is we're not going back to how we were before, and we need to start doing better at figuring out what the future is going to look like. So yeah, fully agree.
I think Penny has just posted something that will make us all start applying for jobs in NHS Devon. 4 hours per month for wellbeing activities.
It's not NHS Devon. Don't let me
go on then. Tell me.
It's somewhere else.
It's National Centre for Creative Health. I'm hosted in NHS Devon, but my actual employer is National Centre for Creative Health, and I think it very much speaks to that. You can't model as a charity. If you can't model as a charity what it is you're expecting other people to build into people's working lives, then what are you doing? But
completely.
Wow, go ahead.
Sorry. No, I was saying part of the discussion is around the employer responsibility is possibly having a mandatory framework for how we collect or what we collect in terms of that data. That's workforce health disclosures. It exists across countries around the world. It's not new. Someone mentioned social responsibility is not new either, right? Climate took us a long time to get us here. We're hoping that health picks up a bit quicker, but it does work. We know that regulation works, but as Chris mentioned, and most of you on here in the equity network, is how do you make this equitable, especially for SMEs that don't have this administrative capacity? But we think there's room to help with that regulatory push and create a more equitable environment that focuses on some of these working conditions, especially as ways of working are emerging.
Thank you.
I think that's almost a very good last point in a way, because one of the themes which I felt was coming through some of the questions, the one that I have. Ewan, if you wanted to come in with a question, I saw your hand flicked up there for a moment. It'll stop me rambling for a start. Put your hand up again, Ewan, if you wish to do so. One of the things that often comes through when we start talking about work for health is that there's a default to thinking, well, what can we do that will enable people to look after their own health? And I always try to force it back and say, well, shouldn't be looking at what the employer can do to help to shape the workplace, and not even just the workplace, but also the nature of employment and short-term contracts and so on not being a good thing for health. What's your feeling, Chris and Elizabeth, and maybe this is the last point, about where the balance lies between, say, the individual's responsibility, the employer's responsibility, and government's responsibility in looking at health and work and productivity?
I'll go first. I'll leave Elizabeth with the last word. I think this is a constant battle. I think we've done a very poor job in the last 50 years of enabling people to look after their own health. We live in a society with a whole load of commercial drivers that are making people unhealthy. Our employment practices have made people unhealthy, and we haven't provided the health services that have allowed them to keep themselves healthy. And I think it's everybody's responsibility. Yes, I'm not going to take away the personal responsibility of that individual employee to maintain their own health and well-being, but we've got to give them the tools, we've got to give them the resources, we've got to give them the environment in which it's possible for them to maintain their own health.
I concur. I will say, behavioral economics, we look at choice architecture. And we've made the poor choice the easier choice. Let's make the healthy choice the easier choice. And that does start with government, but we fully support that ground up approach. The bottom up that says this is enough. If we're not capable of making the best decisions because they're not laid in front of us. So the employer, just like they have a physical health and safety responsibility, absolutely has a psychological health and safety responsibility to provide those working conditions, to enable agency within individuals to make good choices. And that does start and wraps around with regulation. So we can't wait for government really to make those decisions. So that's why we're so passionate about employers and businesses taking ownership of this, giving power back to the people, to the citizens, and making this a more equitable opportunity for everyone.
Excellent. Thank you very much. Penny, I'm going to give you a word here. PPE is VAT-free. So for me, that means personal protective equipment. Is that what PPE means?
Yeah.
Yeah. Okay. Yes.
And would be a great VAT-free option for businesses.
Yeah.
Excellent. Well, I'll draw it to a close there. Thank you so much, Elizabeth and Chris. That was really interesting discussion. And I feel like we've only touched the top of what we could have discussed. We could be going on all day here. Also, an excellent range of points and questions, which again, I don't feel like we've done justice to the so many that we've had. Please, people, do follow it up afterwards with the connections that you've made here. And do join us again in a month's time. This is at the point where I forget what we're actually doing next month, and Alison comes in and reminds me. Where are you? There you go.
Our next month for May is actually going to be Members Month. So I don't remember how many of you would have been here. I think this time last year we were probably only at about 800 members, and now we're near to 2,000. So there's an application process where we send out a Google form and you write a quick application about what you'd like to present. And then we choose 3 speakers who are going to present on their different projects on health equity from around the UK. And then we host a webinar about it and we talk all about it. And it's actually really great. I think last year we had someone from Gwent. We had someone from London. And we had someone from, was it Manchester, Alan?
I'll say yes, because I can't remember.
Okay, all right, that's fine.
Yeah, it was Manchester, of course.
Anyway, it was a great time, and I hope to see many applications from everyone on this call, because you're getting advance notice of the fact that it's upcoming. So looking forward to reading those.
Thanks again, Chris and Elizabeth, and thank you everybody for joining us. See you in a month's time.
Thank you. See you soon.
Bye.